The PPDA, or the Psychophysiologic Disorders Association, was founded in 2011 by a group of very diverse professional practitioners who had started out in life in completely different areas of medicine and mental health, but we all found our way to this condition of physical symptoms that are real and not connected with a structural abnormality or body damage or an organ disease. And we just found each other answering each other's questions in identical ways, and just had a meeting of the minds, and we knew that we had to create a nonprofit that could serve as a vehicle to educate the public, educate medical professionals, educate mental health professionals, because almost nobody has had any formal training in how to diagnose and treat this condition, despite the fact that the number of people who have it is 60% bigger than the diabetic population, for example. So it's millions of people who are falling into what is essentially the largest blind spot in the healthcare system. And that is an injustice, frankly. And we felt that we needed to do everything we could to reverse that. And that's the mission of the PPDA, is primarily education, but we also support documentary films, we support randomized controlled trials, we support educational conferences, and every year that goes by we get bigger and we're able to do more. And we look forward to the day when treatment of this condition will be as routine as management of anything else. The ppdassociation.org website has an abundance of resources, and they're growing all the time. We have the context questionnaire that can help people assess themselves, their own symptoms, and their general life context to see if they fit in with other patients who have had stress-related illness. So that's a great place to start if you've got the very common question of, could my personal symptoms fall into this mind-body stress-related category. We have videos, and we're going to be adding to those all the time. We have a letter that you can give to your loved ones to explain this form of illness to them, because that's often a challenge for people. We have another document that you can give to your physician if you find that you're making progress in this area, because most physicians have not had formal training in this condition, and it's very helpful to them to know that you've made progress with a particular form of treatment that they can then recommend to their other patients, because every physician is going to see several patients every day that suffer from these illnesses. So we're adding resources around this illness to the website all the time, so it's worth coming back every so often to check up on what we've been doing. Chronic pain is clearly a hundreds of billions of dollars issue in the United States alone. And many patients with chronic pain have a significant psychosocial stress component to their symptoms and to their disability as well, that typically is not being addressed, because again, we have this problem that few medical clinicians have had formal training in the kinds of psychosocial assessments that are needed to uncover those issues, and few mental health professionals have had formal training in what to look for in people who are physically suffering. So what we offer from the PPDA is how to look specifically for the kinds of psychosocial problems that are particularly common in the chronic pain population. And it turns out, when those are addressed, the symptoms start to improve. And when they do that, then you've offered that patient an alternative to their opioids. And you're going to be able to taper those opioids much more effectively. If you just try to taper the opioids without giving the patient anything else, it's going to be a struggle. And every physician who's worked in this field, myself included, knows that struggle, how hard it is to persuade somebody to bring their opioid dose down without doing anything else for them. But what we offer in the PPDA is a range of techniques that do offer something as a replacement, something else that patients can use effectively while their opioids are being tapered. And when we can do that, their risk of dying is obviously vastly reduced, the cost of the medication is reduced, and their outcomes and their disability levels are vastly improved. The greatest thing about the PPD Association, or the PPDA, is the collection of doctors and mental health professionals that make up our supporting board. A level of experience in this group is, each of them has decades of working in this field. And each of them brings their own personal perspective, their training background, their patient experience to the table, and enables us to combine all of that in a way that provides the best possible techniques for assessing and treating patients. There isn't any other group that I know of that brings this level of background into a combined approach. There's really nothing else out there that can come close. The membership of the PPDA is national in scope. We have experienced people from everywhere, from Los Angeles to Boston and many places in between. But we bring in contacts from other English-speaking countries around the world to give us support, to give us new ideas, and to interact with them on a regular basis. So we have a global reach, and practitioners that work with us are also distributed globally. We are looking to build a community of people who are experienced in this field from around the world so that we have the best possible techniques for improving outcomes. One of the great things that the PPDA is able to do is and we've seen it in the group that was trained in these methods in the Albany, New York area, is that patients who present themselves to the system with a psychophysiologic disorder, instead of being placed in a blind spot, now their needs are met. Their underlying diagnosis is uncovered. The problems that they're suffering from that are creating their symptoms can be addressed. So instead of getting essentially no care that's aimed at their underlying problem, they're getting appropriate care, effective care, care that changes their outcomes. So it's a night and day difference for these patients, and the outcomes that you see are just as rewarding as you can imagine for everybody concerned. You know, probably the biggest single barrier is that we're asking people to learn a new technique. And you know, it may take a day's worth of seminars for people to become comfortable with this and confident in using it in their daily practice. So that's a barrier, you know, spending a day learning new ideas and then being uncomfortable at first and maybe taking a little bit more time at first in your practice to use them. But in a very short space of time, you're going to be comfortable with these and be able to use them the same way you do any other technique that you learned in medical school. So I think that's the biggest barrier, is just accepting that a new technique needs to be learned. Somewhat like a general surgeon going from open techniques of surgery to laparoscopic techniques of surgery. It's a learning curve. But once people get past the idea that there's that barrier there, the job satisfaction, the clinical outcomes, the reward from using these techniques and seeing patients improve that formerly were a huge source of frustration. Once people see that, they will never go back to the way that they used to practice. There are lots of people out there who can apply a particular medical technique but may not necessarily be able to teach it. But the group that came together to form the PPDA loves to teach. They put on conferences, we put on conferences, we teach in graduate schools, we do webinars, we go all over North America and Europe teaching these techniques. And people go home from our conferences and they can apply them confidently, because there's not a huge amount of magic around this. It's something that almost any healthcare professional, either medical or mental health, can graft onto their existing skills and begin using them right away in their daily practice. And we've got, again, years and years of experience. I personally have been teaching this since the 1980s to medicine residents and physician assistants and nurse practitioners and physicians, primary care, gynecology, general surgery. Even I've taught hospital chaplains, I've taught radiologists. I mean, they all can learn these ideas and use them. So we've got a unique capability here to communicate our decades of experience in a relatively short space of time.